Yeah. A very warm good morning and a very warm welcome to our NITRD CTD NTF Collaborative Difficult to Treat TB Clinic. It is my privilege to welcome you all, the team from Central TB Division, Dr. Ashok Bharadwaj, Chairman NTF, and his team from faculty of all the medical colleges, state TB officers, Director of STDCs, district TB officers, and all the other medical officers who have joined us. We are joined by NIRT Director, Dr. Padma. A very warm welcome, Dr. Padma. And team from NTI Bangalore, senior faculty, Dr. Rajendra Prasad, Dr. Jayakishan, sir, a very warm welcome. Now I request our director, Dr. Ravindra Diwan, to give his introductory remarks.
Good afternoon, everybody. Thank you so much, Dr. Nita, for arranging this difficult to treat TB clinic, which I am sure is being now eagerly awaited every month by the TB community, the workers, community of TB workers in the country. And I'm so happy I welcome Dr. Bhardwaj, Dr. Jayakishan, Dr. Rajendra Prasad, Dr. Alpa, and all those senior people, Dr. Anuj Bhatnagar, and senior people who have joined us for this thing. And as all of you know, that Dr. Deepak Singla is our expert and person who is the main guiding force behind starting this difficult to treat TB clinic. They're with us, and Dr. Nita is taking painstaking efforts to organize it every month. And its attendance already 119 participants have joined. And I'm sure that 500 to 600 is our usual attendance. It will join very soon. We have an interesting case being presented by I'm not sure, but Dr. Nita will tell you. And we look forward to the deliberations in the. Thank you, Dr. Nita. Please carry on. Yeah. Thank you. Thank you so much.
Thank you, sir. Thank you so much. And before I go for today's program, how we are going to go, I would just like to make a small announcement. As we are aware that now this difficult to treat TB clinic has been replicated with the help of Echo India to different states in India. The program is now functional in more than 24 states, and they are running the state level difficult to treat TB clinic. So now it is decided that these clinics, the state clinics, will shortlist at least one good case from their state, and they will be presenting it at the national level. So we will be inviting them on rotation to present their cases and bring them here. So kindly shortlist those good cases which you would like to bring on to the national level, and we will surely present them here. So with that, I start today's program. So today we have a case presentation from RBI PMT Delhi. The case will be presented by Dr. Upasana Mittal, and the expert for the case is Dr. Anuj Bhatnagar. Dr. Anuj Bhatnagar, sir, you are there?
Is there?
Yeah. Okay. So Dr. Anuj Bhatnagar is the head of the department Pulmonology and Tuberculosis at RBI PMT. He is also the member of National Technical Group, which is involved in writing the PMDT guidelines. So a very warm welcome, Dr. Anuj Bhatnagar. And now over to Dr. We have our national expert, of course, Dr. Rupak Singla, who's head of the department at NITRD, who will be discussing the case along with Dr. Anuj Bhatnagar. So over to Dr. Upasana for case presentation.
Good afternoon, everyone. Today I will be presenting a difficult to treat TB case from my hospital. Is the screen visible to everyone?
Yes, Upasana, we can see it. Could you get it on presentation mode?
Yeah. I have shared the screen, ma'am.
You have to enlarge the slide now. Go into the presentation mode.
Yes. Good afternoon, everyone. Today I am presenting the case of a patient who is 14 years old male child on all oral longer regimen for MDR-TB, was admitted at a nodal DRTB center RBI PMT on 22nd of October 2021 with complaints of swelling and pain on right thumb and bilateral ankle joints. Patient had complaints of discharge from the right thumb swelling side and pain radiated to the rest of his finger and arm. Also had a difficulty in walking due to swelling on bilateral ankle joints affecting daily activities. Patient had no complaints of any fever, cough, night sweats, loss of appetite and weight.
Dr. Upasana, sorry to interrupt, your slide is not moving.
Okay, ma'am. I will check again.
Yeah, maybe you need to reshare.
Yeah, I will.
If you want, we can share it from here.
Yes, ma'am. Sure, because maybe the signal is weak here.
Okay, so please stop sharing the screen and we'll do it from here.
Okay. Stop share. Yes. Good afternoon. The patient is a 14 years old male child on all oral for MDR-TB was admitted at Nodal DRTB Center, RBI PMT on 22nd of October 2021 with complaints of swelling and pain on right thumb and bilateral ankle joints. Patient had complaints of discharge from the right thumb swelling side and pain radiated to rest of his finger and arm. Also, he had difficulty in walking due to swelling on bilateral ankle joints affecting his daily activities. Patient had no complaints of any fever, cough, night sweats, and loss of appetite and weight. Patient has previous history of ATT for around 3 episodes, and all the initiation of the treatment was done for every episode was done at Kalavati Saran Children Hospital. The chronological order of episodes are as under: in 2015, when the patient was around 7 years old and around 20 kgs of weight, anti-tubercular treatment was taken for 1 year for the complaints of right upper limb monoparesis, right upper motor neuron, 7th and 12th nerve palsy for tuberculoma. On the basis of MRI, it was taken for 6 June 2015 to 6 June of 2016. This picture is showing MRI, which is showing tuberculoma. On the basis of this, ATT was given. Next slide. And again, the patient had complaints in 2018 when he was 10 years old and around 34 kgs. Patient had taken ATT for bone TB, in which the treatment included tablet isoniazid, rifampicin, ethambutol, and ofloxacin on the basis of X-ray of hand and ankle, which was done on 19th of March 2018. Treatment was given for around duration of 18 months. And it was given from 21st of April 2018 to October 2019. In 2019, again, when he was 11 years old, around 42 kgs, he was again referred from Kalavati Saran Children's Hospital to restart ATT for similar complaints, and a sample of synovial fluid was also collected and subjected to CBNAT. Dated 25th of October 2019, the report was MTB detected and rifampicin resistance. On 31st of October 2019, the patient's smear was negative and culture was negative. And on the 13th March 2021, smear was negative and culture was contaminated. Now the post-treatment history. Samples were sent for LPA and liquid culture DST on 31st of October 2019 from Lady Harding, and no growth was reported till 16th of December 2019. The patient was referred to Nodal DRTB Center, RBI PMT, and he was initiated on ITR 8th of November 2019. The treatment was given was injection kanamycin, ethionamide, cycloserine, linezolid, clofazimine, pyrazinamide, along with pyridoxine. The Nodal DRTB Center had planned to start Delaminate, but due to the non-availability of Delaminate, it could not be started. This ITR was based on the regimen, which on the pretext, which was published in 2017. The next slide is showing the picture of that regimen, in which if the in the all oral regimen, if the bedaquiline is excluded in the first 6 months, then use Delaminate, And if the delaminate cannot be used, then pyrazinamide, amikacin, or ethionamide was given. And if both delaminate and pyrazinamide was not used, amikacin and ethionamide was given. That's why it was included in the ITR at that time. Next slide. Sample for culture DST was sent on 13th March 2021, was found to be contaminated, which was reported on 30th March 2021. Total 90 months of treatment was given, and it was completed on 3rd of June 2021. Patient was advised to go to Kalavati Saran Hospital, but it was COVID time, to take further expert opinion of the orthopedician, but the doctors advised him their admission for the biopsy. The patient did not comply and continued with ESI hospital. There, his MRI right ankle joint and thumb was performed and inferred that it was likely a case of chronic osteomyelitis. Medicines were stopped at the time of ESI hospital, and the outcome was given as treatment completed. Next slide. This is the X-ray of that time at the time of the treatment completion. And next slide. Further investigations done by ESI on 30th of June 21 was MRI was showing chronic osteomyelitis, and MRI thumb was showing soft tissue lesion with cortical destruction, likely chronic osteomyelitis. Next slide. This is the MRI of the thumb, which is showing the soft tissue destruction. Next slide. Now the current scenario, after having stopped all the medicines at around 8 June 2021, after 19 months of ITR, a slide before, the patient kept on being follow-up of doctors of ESI Basaidarapur. After about 3 months of patient again had growth again around his right thumb and bilateral ankle swelling in around September. The doctors did a tissue biopsy of the thumb, and the same was sent for further investigations and NDTB lab. The tissue biopsy showed stain for AFB 2+ positive. First line LPA was rifampicin resistance was detected. INH resistance was detected at high level. Second line LPA was showing fluoroquinolone resistance with levo and moxi resistance was detected. The mutation pattern was in first line was RPO, WT3 and 4 was absent and mute was absent. And in second line LPA, gyrate, WT was absent and mute 3C was present. Patient was referred to RBI PMT on 5th of October 2021. Now the patient is on current regimen. The current regimen advised by the nodal DRTB center at around weight of 46 kgs on 29th of October 2021. Regimen includes bedaquiline, injection amikacin, high dose moxifloxacin, linezolid, clofazimine, cyclosarin, ethionamide with pyridoxine. Delaminate was not available at the time of the treatment initiation, and requisition for delaminate was sent through ST office. Injection amikacin was stopped on 11th of November 2021 due to the swelling on the injection site, and the tablet delaminate 100 mg twice daily was added on 11th of December 2021. The main adverse drug effects experienced by him was nausea and vomiting for initial 2 weeks. Now the current weight has a patient having 52 kgs, an increase of around 6 kgs in the weight. These are the pictures which are showing before the treatment. It is showing ulceration, and the pus is also oozing from the ulcer. And this is the next picture is showing after 3 months of the treatment, the ulcer has healed completely. Now the issues during this treatment was the use of fluoroquinolone in OPD prescription treatment for extrapulmonary tuberculosis, and expanded DST for pyrazinamide, linezolid, clofazimine, and moxifloxacin is also not readily available. Supply chain issues for regular cultures, use of therapeutic drug monitoring for anti-TB drugs and its linkages, extended treatment for certain EPTB patients like skeleton and neurological TB, and regular and timely supply of delaminate, and expert XDR-TB testing in the country for faster turnover time and better guidance for planning of the regimen should be included. Thank you, sir.
Thank you, Dr. Upasana. It's a very well presented case. Thank you so much. Now, before I invite Dr. Anuj Bhatnagar for his comments, I will just summarize the case for the people who joined later, and then we'll take questions if you have any on this history. So this is a case which is a 7-year-old child in 2015 who had CNS TB, a tuberculoma, and he was given EHRZ from 2015 to 2016, and then patient was declared treatment completed. After that, patient had first relapse, and patient was given levoflox with EHRZ in 2018 and 19. Then patient had a second relapse with bone TB in 2019, and that time patient was 15 years of age, and patient had RIF resistance, and patient was given individualized treatment regime without bedaquiline, as bedaquiline was not allowed less than 18 years of age at that time. And patient was put on injectable kanamycin, ethionamide, cycloserine, linezolid, clofazimine, and pyrazinamide till 2021. Now, patient had a third relapse in September 2021, and a tissue biopsy done, and LPA showed pre-XDR-TB. As patient had received most of the anti-TB drugs, it was a challenge to make a regime. So patient was started on a regime with bedaquiline, injectable amikacin, high-dose moxi, linezolid, clofa, cyclo, and ethio. So now patient is open for discussion. So I would invite any questions to Dr. Upasana on the history of this patient. Please raise your hand if there are any questions, or you can type them on the chat.
Dr. Rishi Saxena.
Okay. Yes, Dr. Rishi. Please unmute yourself.
Yeah, this is very well presented. My concern is that the photographs of the right thumb shows initial, and after 3 months it has been cured. But just we want to know is the flexion of the thumb is going on or not, and whether was there any need of surgery for this or not, madam?
No, sir. No surgery was needed. It was cured by medicines only. The skin is completely healed, and only some pain is left in the ankles. Thumb is completely moving normally. No surgery was required in this case.
Okay, thank you.
Dr. Padalal ka question hai. Why amikacin was changed? We could have started IM.
I wanted to ask
that a technical issue here, and we are trying to sort it out. So can you hear us?
Yeah, yes.
Dr. Alpa, can you hear me?
Yeah, yes, I
can
Dr.
hear
Alpa,
you. Please, you have a question. Can you come up with your question?
Yes. So, as such, this patient with the history of 3 treatment taken in the past, and also now that we have started him on bedaquiline, delaminate, and amikacin, which is showing sensitivity. Bedaquiline and delaminate sensitivity we do not have, but rest of the other drugs that we are using in the regimen, linezolid and clofa, is cycloserine, is already been used in the past. So we have probably 3 drugs which amikacin, which is never which is still showing sensitivity. And bedaquiline delaminid we have not used. So we assume that it would be sensitive. So with that, why should we not give him amikacin for a little longer time? Because this is the last chance that we have to cure him. And the reason why it was stopped was because he had some swelling. So we could always change it over to injectable or put IV and give him. This is my question and comment.
Yeah, thank you, Dr. Alpa. I think it's expert Dr. Anuj will be taking up this question. Right now, we are taking questions pertaining to history. If you need more clarification regarding history of this patient, then Dr. Upasna can give us the history, and then I invite Dr. Anuj for his comments. Yes, sir. Dr. Rajendra Prasad, sir, wants to say something.
Thank you, Neeta. One thing, it was surprising for me that the case weight as he or she progressed, weight was constantly increasing. I think he started with the age maybe weight with about maybe very less weight, and now he's showing that he's about 42. So that dictum what we used to teach to our student that there is a loss of weight in tuberculosis. In this case, it doesn't appear to fit. And to me, it appears that he has been a primary drug-resistant case from very beginning, because he never responded, and now he has responded with a new regimen. What you have told. So I was asking about the weight, from which weights he started, and then ultimately.
Sir, he started at around 42 kgs, 46 kgs when the treatment was started, and in around 3 months, it was raised to 52 kgs now. On 5th
No, from the very beginning, I was asking.
Sir, yes, sir. The weight has not.
At the time of the first treatment.
He was actually, sir, 7 years old at that time.
Yes. So what I was trying to say, as his age increased, his weight continued to increase.
Yes,
there is nothing like weight loss or anything in this clinical picture.
Dr. Upasna, there is one question by Dr. B.K. Vashisht. Was there any pulmonary involvement in this case or any other EPTB site involvement?
No history in the close contacts.
Pardon?
No history, no close contact history was there.
No. Was there any pulmonary involvement in this patient? Chest X-ray was done?
No, sir. There is one X-ray also. I can show. I have kept it in the last. There is no pulmonary involvement in this patient.
Okay. Was there any past history of? Was there any history in other family member or so?
No history. No significant history in the family members.
Okay. So these were the two questions pertaining to history.
This is the X-ray of the patient. It was in 2021.
Stop share.
Okay, thank you, Dr. Upasna. Now I invite Dr. Anuj Bhatnagar for his expert comments.
Thank you. And now I'll start my screen sharing.
चश्मा कर रहे
as you can see from this patient, that he is a young child with skeletal TB at 3 different sites. Now, these sites, in fact, in the current episode, this patient is having involvement of the right thumb, the right and the left ankles. One of the ankles has been involved for the first time. where he went to one of the leading institutes, one of the leading government institutes for pediatrics. That is Kalavati Sharan Children's Hospital, Lady Harding Medical College, where he was treated. He was treated for TB. And at every particular point of time, he complied with the treatment. In the second time, he had a skeletal involvement. For the first time, he took treatment for around 12 months. And the second time, he had skeletal involvement. That's the time when he first had involvement of the right thumb. And at every time, it's not that the sample could be taken out. It could not be taken out. The sample was taken out. Now, the second episode, the interesting part is, in this episode, this is the second episode of being treated for a clinical reoccurrence of a drug-resistant TB. I mean, a clinical reoccurrence which has been proven to be a drug-resistant TB. Now, every previous episode, like I said, has been under the guidance of the concerned specialist. Now, we keep on saying that, well, the concerned specialist, the patient should be referred to a concerned specialist. This is every period. So here, this is a patient who has gone to a neurologist. He has gone to an orthopedician. I mean, he has come to the DRTB center. He has taken the treatment as per the guidance. And more importantly, if you see the history from the last time, despite stopping the treatment, the strict instructions were given to this patient that the treatment will have to be stopped only when the concerned subject specialist decides to stop. And that's what he followed. And he was also told to get followed up at regular intervals. That's exactly what we teach, and this is exactly what we follow, especially in every TB patient and especially in every extrapulmonary TB patient. And the treatment duration has been as per the guidance of the subject specialist concerned. So what has happened? I mean, only once has the patient taken treatment from outside the National TB Eradication Program, that is RNTCP. That was when he had treatment for 1.5 years, when he took rifampicin, INH, ethambutol, and ofloxacin or levofloxacin. Now, it's not that surgery was not planned. People have asked the questions and in the chat that surgical debridement, why wasn't it done? Now it is done. It was planned. The patient refused. The patient's parents were told, the patient is a child, you can't force him on the OT table. But he finally, in fact, when they were able to do it, whenever the cultures were sent, they were either negative or contaminated. Obviously, you expect this in an extrapulmonary sample. You expect it that this thing, like we talk of, say, in the first episode when the patient had neurological TB, was any CSF done? Well, that is something which I scanned every single paper, and the patient had a pile of it. I and Dr. Upatna scanned every single paper. I could not find a record of a CSF being done. And obviously, in a tuberculoma also, people will agree that the yield of mycobacteria or mycobacterial DNA in a CSF is quite low. And see the problem. The patient has used what all drugs have been used: rifampicin, INH, ethambutol, pyrizinamide, the quinolones, kanamycin, ethionamide, cycloserine, linezolid, clofazimine. And I mean, we are left, like Dr. Alpa said, we are left with too fewer drugs. That's what when we finally decided, when we sat down to decide our treatment, we were actually at our wits' end what to do, but something had to be done. Now, but one thing is clear. Now, obviously, the availability of regular cultures, we all know the practical ground reality for the last 1 year or year and a half. How many IRLs are actually getting the material for performing the cultures or the line progresses or what? Now, availability of PAS, availability of Delavan at least on 2 occasions has been a huge concern. Every one of us is facing. Now, it's not that the patient didn't respond to treatment. Now, the patient actually responded to treatment every time. The subject specialist, the concerned specialist thought that, well, the patient is fine enough and we should stop the treatment. But the patient always relapsed. So you have a patient here who is always, in fact, relapsing. He is relapsing for the 4th time. So I'll discuss the available DST reports that we had. Now, this is the latest DST report with which he's being presented now. Now this is it is from the IRL. The direct smear in the tissue was 2+, and culture was put up. Culture could not be put up. In fact, we tried our level best. In fact, a culture was ultimately put up which was contaminated. But his line probe assay, both the first line and the second line probe assay, it was a mutation pattern. That for rifampicin, you can see it is both wild type 3 and 4 were absent and mut 1 was present. For CATG, wild type was absent and mut was absent. For INHA, wild type was present, mut was absent. For in second line probe assay, Gyrus A, wild type 3 was absent, mut 3 was present. And in second line injectables, wild type present and mut absent. So based on that, it was concluded that he is rifampicin resistant. Now this is from September 21. Rifampicin was resistant. High dose INH could not be used, but ethionomides could still be used. The quinolones could not be used, both in low dose or high dose, normal dose or high dose, but the second line injectables could be used. So now what? And once again, like I said again, culture could not be done. It was ultimately done with great difficulty outside and it was contaminated. So we worked with the limitation that there was no information on the availability of resistance pattern to pyrazinamide, to high dose moxifloxacin, which is important for to be confirmed on phenotypic DST. Every one of us knows that, and it is as per the WHO guidelines that it is important to be confirmed from phenotypic DST. We didn't have any information on streptomycin, on linezolid, and clofazimine. So the only option was to design a regimen based on his past treatment history, based on his response to treatment, and keep him under regular follow-up and arrange drugs, whatever were left, to the best of our ability. So I'll just tell you, feel free to criticize. I'll tell you what we decided, and Dr. Upasana has already told you the response. So in this table, basically I have shown what are the status of DST and past use and what was the decision ultimately on use. You can see that bedaquiline was not used in the past because previously it was not allowed in the age of less than 18. But this time, since it was allowed, it was started in this regimen. What about quinolones? Now, in that 18 months of treatment that he took with quinolones, it was slightly lower as per body weight for 18 months, but he responded. And the second line probe assay showed resistance was detected. So this was not added. But for what about high dose moxifloxacin? Though the second line LPA showed mut 3C and it was never used in the past. Now we started it. The only rationale that available to us was that since there is no phenotypic DST confirmation available, and that is something which I think some of us have been repeatedly requesting the data from the Central TB division regarding the analysis and correlation of the high dose moxifloxacin mutation with the phenotypic correlation in our IRLs. That is something which people like Dr. Singla and I have been asking the Central TB division to make a data available. Now, linezolid was used for 18 months, but we didn't have the DST, but it was started with the low reliability as the previous episode. In the previous episode, the patient showed a response. Same thing with cycloserine, same thing with clofazimine. Delamanid was not used in the past, as it was not available in 2019. So it was added to the regimen in January, or rather December, correction. It was not available in 2019 and it was not available in October 21. In December, it was available. I'll thank Dr. Padma for it. It was available and then we were able to start. Now, amikacin, kanamycin had been used in the past, but the second line probe assay showed sensitive. But it was started in the regimen, but it was stopped not only due to swelling, but the patient also started complaining of a bit of ototoxicity. So that is the reason, that's the reason why, Dr. Alpa, I was not able to explore the option. It is obvious that yes, we can give an IV, put an IV and continue amikacin. That's very well, and that's very well known. But in this particular patient, he had these two problems. Pyrazinamide was used twice in the past, and we didn't have any DST, so it was not added. Ethionomide was used in the past, but this time there was no INHA mutation pattern. So it was started in the regimen. PAS has never been used when we didn't have any DST, but it is not added because of the availability issues. Ethambutol not added, but one of the options is PENEMS. Now, there are many issues regarding PENEMS which we all have discussed, which we all know. I'll continue to raise this, in fact, in the future slides. So currently the ongoing regimen for this patient is bedaquiline, high-dose moxifloxacin, linezolid, cycloserine, clofazimine, delamanid, and ethionamide. Well, this is the current status of the patient, and these are the future plans that we have made. Well, the current status is that since October, the patient has improved. His wound has healed. In fact, his wounds, I should say wounds. In fact, he had, we actually could not get the pictures, the pre-treatment pictures of both the ankle joints. He had discharging sinuses and huge swelling on both the ankles. In fact, he was not able to walk in October, and now he's going to school. So this is what it is. I mean, his wounds have healed. He has gained 6 kg of weight. He's tolerating the treatment well, and his regular follow-up, he's being regularly followed up by an orthopedician. You can see he doesn't have a pulmonary involvement at all. Now, what is our plan? Now we plan longer duration use with both bedaquiline and delamanid. Now we plan that regimen should be extended till radiological and clinical stability is achieved for at least 6 months, at least. I mean, this is something which in this particular case, I might need to, in fact, extend it beyond the recommended time frame also. Now there is, since he is last time, in fact, he was an ESI beneficiary. This time we are not sure of that, but we have planned a regular monitoring with whole body PET scans through ESI. Now the patient is, I think he's still an ESI beneficiary, and we have planned that we have to map his hidden foci. Basically, I think we have in fact studied in the past also, and we have seen patients in the past. We have been regularly doing it for recommending it to the patients for PET scans, follow up on PET scans, to see whether there are any foci who have not clinically manifested but are still there, which can be sampled. I mean, the aim is not to see that there is to actually map everything, every inflammatory focus in the body, in addition to monitor it, and more importantly, whether it can be sampled. You never know, you might get a culture from there. Then we still we are once again, I mean, since we don't have a phenotypic DST with high dose moxifloxacin, I want to replace it with PAS and PENEMS. The problem is the availability and the PIC line. The patient is not willing. The patient's parents are not willing. 12 early infusions are required, and ESI option is still being explored. That please make sure that PENEMS are given, because we will like to start PENEMS in this particular patient as soon as possible. Now, yes, malabsorption, always a question in the mind, and any genetic predisposition, say Mendelian susceptibility to mycobacterial diseases, but the chances are low. The patient actually, these patients in fact have the reality is there, but these things are at the back of our mind. But one thing that we have decided in this patient, that yes, whatever happens, surgery and surgical management is an option. We have actually made sure that in this particular patient, the orthopedician, the patient and the patient's parents have been told that this time, please do not refuse for surgery, because at any particular point of time, we might require samples. And in this patient, we will definitely request for the therapeutic drug monitoring. I mean, if you see in the second episode, when the patient had a relapse, that's a time when a therapeutic drug monitoring, if say availability was there, could have easily been done. But we all know the availability issues. Now we still send our samples to NIRD Chennai, and also only now quite a number of second-line drug samples, therapeutic drug monitorings are being done. So there are certain issues and learning points from this case. Now, let us face it, we all have seen that disseminated pre-HDR extrapulmonary TB is the reality, and it needs multidisciplinary management and prolonged treatment and surgery. It is something which we all have faced. Now, OPD prescriptions of quinolones as ATT as a routine in many departments, in all government hospitals continue, and private hospitals. It continues. And that is something that is contributing to a lot of problems. We all know that, but that is something which at some particular point of time will need to be addressed. Supply chain issues, I will request once again the Central TB Division to ensure that the supply chain issues for lab consumables and drugs are addressed. Now, just thinking out aloud, if we had expert XTR cartridge availability in the program, I mean, when the patient was confirmed as rifampicin resistance in 2019 on GeneXpert, I mean, expert XTR could have helped us design a better regimen. That is something, I mean, where we could have thought of it. I mean, that is something which can be done. Now, why can't we establish therapeutic drug monitoring linkages, especially in pharmacology departments of selected medical colleges in every state? That is every state or every state program officer needs to think about it. That why can't we think of it? And specialized, why can't we use specialized imaging techniques like whole body PET scan at 6 monthly intervals for monitoring and selecting the sites for sampling? We have established a linkage for a particular patient, but that is only for a particular patient. As of now, these specialized imaging techniques they are costly. I mean, they are very, very costly. Not every patient can afford it. So the big question is, can the disseminated DRTB managed? Now, this is coming up for the future. Can the disseminated DRTB be managed with a treatment regimen of a prefixed duration, especially a 6 to 9 month regimen for DRTB with newer combinations may be introduced in the future? Who knows, after 1 year, you have 6 to 9 month regimen with 3 or 4 drugs coming up. Now, in extrapulmonary MDRTB, in disseminated DRTB, these are things which we must actually, in these patients will require extra management or extra duration of management. And the most important take-home point from this patient is regular and active search for a likely involvement of other extrapulmonary sites. In every extrapulmonary case, at least at the start and change of treatment phase, and at the end of treatment is a definite recommendation. I mean, this is something which this patient started off as an extrapulmonary TB. It continued as it relapsed as an extrapulmonary TB. I mean, this continued. This kept on continuing. So these are the things that are important in this particular case. So with this is all I need to say as of now. I'm happy to. I'll hand it over to Dr. Rupak for his expert comments. Thank you.
Thank you, Dr. Anuj. A very fruitful discussion and a very nice discussion. Before I invite Dr. Singla, we'll take up questions. Dr. Padma has been trying to say something. Sorry, Dr. Padma, I could not call you earlier.
Thanks, Dr. Neeta. So that's okay. I mean, when we got lost in between. Thank you, Dr. Anuj. That was very interesting. I just have 2 questions and 1 comment. What was the age of this child? Sorry, I missed it when Upasana was presenting it.
Okay, Dr. Padma, when in 2015, this patient was 7 years of age when he was diagnosed to be a case of tuberculoma, right? And then currently the patient is 13 years of age. So that's what it is.
Okay, so thanks for that. And the second thing, he's a primary case, right? There is no other TB positive cases at home, because there
are no TB positive cases at home. There are absolutely no TB positive cases at home, and that is something which has been inquired and that is there in the history.
Okay, so thank you. That was the 2 questions and suggestions that I wanted to discuss was the drug level. So we do have now drug level estimation both for linezolid and moxifloxacin. So I wanted to put up a request to the difficult to treat clinic, Dr. Singla also. The 2 things that we would be more than happy to help patients here would be TDMs, a drug level for second line drugs, including linezolid and moxifloxacin. There was 1 question that Dr. Anuj asked. We are not getting the DST of high dose moxi. So these are the cases where you can ask for a sequencing and try to correlate if you think there's going to be difficult. I agree there is a discrepancy between genotypic and phenotypic. But this child from 7 years to 13 years has been going through a lot of sufferings. In such cases, I think sequencing should be given an option, which will give you the DST for all the drugs, including we don't have much to offer them. So I think he should be given the benefit of sequencing. We'll be happy to do it for you, Dr. Anuj, if you send us a sample for all the drugs. And then we can take a call on the availability of drugs.
Thank you, Dr. Padma. This is something which I have planned, in fact. But correct me if I'm wrong. Sequencing is something which you need to do only when the culture comes positive. Am I correct or wrong?
So we have both. We currently have both. We have targeted sequencer where you can do it directly from sample also, but we still prefer to use the culture. That is the third point. So this case, I don't know that Dr. Divan is still there. This is a very ideal case for surgical debridement, and I think now it's time for them to get convinced to go in for surgery, like we did for extremely damaged lung. We for NTM, right? We need to remove the lung if we have to have some kind of improvement. So surgery and debridement should be the first on the list before you even think of keeping on changing drugs for this. The last question is, was NTM ever ruled out? Extrapulmonary TB, non-healing, would be good to also rule out NTM in this case after debridement. So if you get the sample, the tissue sample, many things could be sorted out. Thank you.
Dr. Padma, to answer that, what I'll tell you is that this patient's sample was taken last year, and the synovial fluid and the synovial membrane was taken. It was sent both for culture and for molecular testing, where it was detected to be pre-HDR. So, and the culture came out to be, in fact, at one particular 2 or 3 places, culture could not be done, or ultimately it was contaminated. I agree with you that the moment we get the tissue, that is something that we have already planned. It's already planned with the Dr. Urvashi that we need to send a whole genome sequencing for this particular patient. But yes, this patient has been repeatedly advised for surgery in the past by the orthopedician for debridement. In fact, he totally refused. His parents refused. This is the first time that they are a bit open. So let us hope. This is the first thing in my mind that I need to do, that his ulcer is healing, his foot is still, the focus is still there. As soon as they get an MRI done, I'll ensure that this sample is taken. We'll get a sample and then we'll send it everywhere. We'll send it to you also. Thank you, Dr. Padma, for offering.
Thanks, Dr. Neeta. Thank you, Dr.
Yeah. Thank you, Dr. Padma and Dr. Anuj. Dr. Divan sir, you wanted to make some comments?
Yes. You see, because in NIT RD also several such cases keep on coming off and on for surgical kind of thing. I agree with both the points raised by Dr. Padma. Number one, a good surgical debridement, even on the beginning itself, and leaving the track open actually. Otherwise, this treatment, you can keep on giving treatment. So the recurrences are bound to occur. And the second point is NTM. NTM has to be ruled out, whether in the axilla, such a kind of thing, or any soft tissue part of the body. When patients are coming repeatedly with various treatments, and we have never been able to definitely culture the bacteria, so those two issues are very important. Good surgical debridement, that's the basic principle of surgery, that any wound or abscess, pus anywhere needs to be left open for healing, and then only the complete healing can take place. And secondly, we had cases in which, you see, very long time ago, patients being treated with drug-resistant TB for spinal TB. At that time, in fact, these kind of facilities for culture sensitivity did not exist. Then I remember a case who suffered 2.5 years with this thing, and then somebody cultured simple staphylococcus in the pus and cloxacillin for 4 to 6 weeks. Even that healed the patient completely. So we may be missing something else. You should send the material, take out a good debridement, send the material for all kinds of culture sensitivity. Thanks. Over.
Yeah, thank you, sir. Dr. Jaimin has been raising his hand. Dr. Jaimin? Dr. Jaimin Patel? Okay, so since we are not able to contact him, Dr. Amitesh, can you take the other questions?
Yes, ma'am. There is one comment by Dr. Alba that one should consider prolonging bedaquiline and delaminate for the entire duration of treatment in this case. Dr. Anuj, what is your take on that, please?
I think I've already said
Already
it
said,
clearly
right.
that I'll continue both the drugs for the entire duration of treatment. I've made it clear in my presentation.
Right, sir. Right. Thank you, sir. Then there is one question by Dr. Jackishan that what about the local application of drugs in case of discharging sinuses, as it was being done previously in case with isoniazid?
Well, that is something which, in this particular case, I am open to suggestions. Let me be very frank. I am a very frank person. Let the senior persons like Professor Rajendra Prasad throw light on it.
Sir, please unmute yourself, Dr. Rajendra Prasad.
Yes. We were we were hearing from so many years that local treatment, especially in the wounds. I know one of the case where even local installation of streptomycin in TVM used to be done. But now currently we don't have any experience of locally applying the drugs. So I think Jackishan can throw some more light. Professor Jackishan.
Okay, thank you, sir. We have another question.
Yes, there is one more question by Dr. Tanmay. He's asking that how common is this MSMD in the Indian setting, Mendelian susceptibility for mycobacterial diseases? And can you please elaborate further on this entity, Dr. Anuj?
Basically, this entity is not been reported. I mean, I've till date, if you ask me, Dr. Tanmay, I have seen 2 cases of Mendelian MSMD. Now it's a rare condition. Now, basically, in this particular case, in this particular condition, it is a rare condition, basically, with the genetic predisposition to being infected with the weakly virulent mycobacteria. That includes mycobacterium other than tuberculosis. In fact, the patients are prone to salmonella, the patients are prone to candida, they are prone to tuberculosis, and with other intrahemorrhagic, macrophagic bacteria and fungi and parasites. So, I mean, it's basically linked to different genes, the interferon, different types of interferon genes and STAT genes, and also for IL-12, all those genes, all those cytokines which deal with the cell-mediated immunity, the Th4 helper cells. So this is basically, I mean, these impair, in fact, only, I mean, these, in fact, this is also not fully known. Now, so, I mean, they may display, they may even remain asymptomatic. So we don't know, I mean, what is the prevalence in India? We don't know what is the, how to rule it out. I mean, it's something that it's basically, whenever the salmonella infection is there, it is a rare, it's basically usually non-typhoidal. Now, there might be chronic mucocutaneous candidiasis. I mean, these things, or there are rapid infections. As such, when the history was taken, this patient, no such thing was, in fact, available in the history. So let us see. It's just something that we need to see. I cannot confirm it. I cannot deny it. Let me be very frank. But as of now, I am keeping it very low in the probability. But
Okay,
I'm not ruling it out.
Yeah, thank you, Dr. Anuj. Dr. Ritu, microbiologist from NITRD, wants to say something. Ritu?
Yeah, good morning, ma'am. Good morning, sir. Good morning, everybody. Just wanted to comment on one thing, Dr. Anuj, sir. I was just noticing this is synovial fluid. It's an extrapulmonary sample. So normally, extrapulmonary samples first go for culture, and from that we do LP. In this case, the LP has been done directly. So had the NTP algorithm would have been followed, and considering that you were getting cultures, because of the logistics problem as contaminated, even this would have been missed. So this is just point to note with so many, people who are closely associated with the program, to actually tell them that maybe LPA could be later on taken directly, which has helped in this case. Thank you.
Exactly. I agree with you. In this particular case, I believe what we have been told is we in fact asked exactly this question. And in this particular case, since his direct smear was positive in the synovial fluid, So they did LPA directly. So you're right about that. An LPA was done directly in this patient.
Dr. Anuj,
Sir,
did you have some test which talks about primary immune deficiency in this particular girl, this particular case?
we have as of now we are basically concentrating on his treatment, but no, as of now, no particular further test has been done for this. In the past, in fact, and like I said, sir, he has been under follow-up with the Department of Pediatrics at Kalavati Sharan. He is under follow-up from Department of Neurology, Orthopedics. I mean, the best medical college for the best college for for pediatrics in Delhi. I mean, what more can we ask for?
Right,
so all these things.
And Anuj, may I know one more thing? What was the socioeconomic status of this patient?
Well, he is an ESI beneficiary. He is low middle class.
Low middle class. So I totally agree with the that the atypical microbiome NTM also, but sometimes some tissue if you get and culture, because you know he has recurrent TB for and very fortunately in extrapulmonary sites every time, but he's likely to recur. So he has to be kept under close constant watch, regular follow-up. And then if we able to convince parents that if somebody we can get some tissue and because atypical possibility of atypical NTM is also can be there, seeing the resistance pattern and everything whatever we are getting. Because to me I feel primary, it was a primary pre-DRTB, no other history in the family, nothing, but still how he got the such type of tuberculosis which is recurrently occurring. That is the question.
I wish to make a suggestion, Dr. Anuj. Can I make a suggestion?
Yes, sir.
Yes, sir, please.
Yeah. You see, this is like my mentor, Dr. R.C. Jain, who was the first director here. I think he was, rather than surgeon, he was a physiologist from the old era when TB used to be treated in sanatorium. So for such cases, here two things to suggest that can we do dressings with cod liver oil or gentian violet. These old sometimes as dressing materials, sometimes they used to sterilize these cases. We continue to do them in extrapulmonary sites if they continue to use as a sinus. And when some kind of surgery is also not possible, we treat them just a dressing with the cod liver oil, which is available, and gentian violet. They have the two options rather than betadine dressings. That can be also tried in addition to whatever you are giving.
Thank you, sir. But additionally, right now his wounds have totally healed.
Healed at this stage.
At this stage, yeah.
This stage,
so what actually is in our mind right now is that we should actually get a sample so that we can actually send it for culture.
And vitamin D3 levels. Vitamin D3 levels.
Well, we are already supplementing it with vitamin D.
Okay.
Thank you. Very nice discussion, and thank you, Dr. Padma. We are getting very good feedback from you, very good comments from you. Dr. Rishi, I would have liked to take your question, but we have already crossed our time limit. So maybe if you can put it on chat, we will definitely take up your question. Now I invite Dr. Singla for his final comments, and maybe you can give us the take-home message. Dr. Divan sir and Dr. Ashok Bharadwaj sir, I would like to inform you that today we are joined by 17 states, Maharashtra, Haryana, Delhi, Himachal, Uttar Pradesh, West Bengal, Karnataka, Kashmir, Assam, Nagaland, Bihar, Jharkhand, Chhattisgarh, Telangana, Kerala, Madhya Pradesh and Rajasthan. And we have STOs from Maharashtra and Delhi who have joined us. Thank you, sir. So that was just a small information. Dr. Singla, over to you.
Thank you, Ropnita. You see, much has already been discussed. Experienced physician like Dr. Anuj Bhatnagar in a presentation, he has discussed that why a particular regimen was used, the various causes, everything has been discussed. Then Dr. Alfa Dalal, Dr. Padma, and various other colleagues have also discussed many of the points. But still, few points I would like to, maybe at the cost of repetition. Before I go for that, you see regarding the NTM, Regarding NTM, because this patient has twice the CB-net positive showing refer resistance and also LPA showing this. So the possibility of NTM practically becomes very, very less. Once the CB-net is positive, the LPA showing MTB present, so NTM possibility, that is atypical mycobacteria, becomes less. Now, regarding this patient, as you see, we call it patient has relapsed 2-3 times. So truly speaking, we do not even know whether he relapsed or it was a poor response to the initially responding and then poor response. Because in EPTB, the end of treatment criteria is not usually defined very well. So it is quite possible that he was responding to treatment initially and then it got static and then come up again. And secondly, yes, it could be a case of relapse also. Now, why do these patients, especially we have seen, as Dr. Anuj also said, most of us have seen repeated relapses in some of the patients and most commonly seen in EPTB cases. So one of the reasons could be poor absorption of the drugs. So there we need to do the blood levels, the facilities for blood levels, especially for the second line drugs is very, very limited in the country. And Dr. Padma has informed that they can do it for linezolid and moxifloxacin. So we should make use of it. So at least 2-3 good drugs we have in hand, but again, the entire country they cannot cater to. It's a request to the Central TB division that we should have more centers where the machines are there, where the people who are trained for carrying out this blood levels are there. There's a dire need for it, and I think in many of the clinics we have discussed this. The second possibility could be, as we discussed, we call it MSMD, the Mendelian susceptibility to the mycobacterial disease. That is a possibility with the primary immune deficiency, and Dr. Anuj has talked about it, that in this case various genes have been labeled, and it could be one of the commonest gene is the autosomal recessive gene linked to the X chromosome. So that could be, this possibility cannot be ruled out in this case. Child was quite young when he started having all this, so we need to investigate on those lines. And one little uncommon possibility that sometimes we find the drugs are not reaching the site properly, and more commonly seen in cases of lymph node or in cases of bone TB, that patient is taking the drugs, there is no malabsorption also, but the drug is not reaching the site. So even that possibility can be there once we find there are cases of repeated relapses. Another thing which Dr. Anuj also touched upon was that it showed the LPA, the mutation pattern showed that moxifloxacin high dose was resistance in the form that the mutation was there and GAR-C was there. So which indicates that there could be moxifloxacin resistance. But if you see the LPA guideline also, it is clearly mentioned that with LPA, we should always subject this patient to the culture and DST, because the LP result alone for moxifloxacin specifically may not be that much reliable. And whatever evidence is there with the CTD from various laboratories of various NRLs, what they find is that once the LP shows it is moxifloxacin high dose resistant, and once the culture DST report comes, in about say 40-50% of cases, it may show sensitive. And even the other way around, the LP is saying it is sensitive and the culture DST may show it is resistance. So that possibility also we have to keep in mind. And now, especially when you are cornered, like in this case, very limited drugs were available with the treating physician. So they decided to choose moxifloxacin high dose, which was a, I think, decision which was very correct in the interest of the patient once you have the limited drugs availability with you. And also you see, we have to simultaneously focus on the availability of some of the drugs, especially like delamanid and PAS. The delamanid is intermittently available for use for the patient, and usually there is a scarcity in the country. So I request again the government to make this drug available, especially for such cases when we are cornered and it's a young child, he has to live life. And in case we get good drugs like this, it is the first replacement drug in the replacement sequence. It can really help the patient. And PAS, you see now, I'm told that is available in the form of 1 gram tablets. So in case you want to give, say, about 12 grams, so 12 tablets of PAS alone, and even that is not available. So availability, we have to work on that it should be available. Regarding the ibipinab cilastatin, Dr. Anuj already discussed, one is the cost factor. It requires PICC line to be inserted. Then you have to give infusion 1 hour in the morning, 1 hour in the evening. The child is going to the school. So logistic issues, the cost issues, they are also there. But I feel in this child, and especially he is a ASI beneficiary, we must make full efforts with Dr. Amish has already said that they are working with the ASI, that imipinam will be a good drug in this case to be used, because we have very, very limited drugs which have not been used. Most of the drugs have been used, and the DST we do not have in hand. We are relying or we are forced to rely on the drugs like linezolid, moxifloxacin, clofazimine, cycloserine, which have been used earlier. So that again will be useful. Then also, as Dr. Anush's team has done, even in EPTB, there was a time when people used to treat them empirically. But no, now with the facility of the radiological investigations like CT scan, MRI, and ultrasound guided FNACs, we must make all the attempts to receive a tissue specimen. In case still not available, the biopsy is the answer, and subjected to the genotypic test, subject to the phenotypic test. Fortunately, in this case, the genotypic test helped us by LP and the CBNet, and culture was contaminated. So, but that is the bad luck of the patient. But we should make our all attempts to have the tissue specimen to be there. Then, as Dr. Amish already said, the expert MTB XDR, I think it is long awaited in our country. Right upfront, within first 2, 3, 4 days, we get the answer whether it is only refrigerations MDR or it is pre-XDR. And then a better regimen could be planned right from the beginning. And we do not lose good drugs, which otherwise we may lose by making a regimen which is poorer for a pre-XDR TB patients. So that also one has to keep in mind. And regarding the prolonged use of bedaquiline and delambanate, yes, we have published from our institute, they using them together, using them for prolonged periods, and even now WHO on their analysis of data, they have found that combined use of bedaquiline and delambanate, there are not much significant safety concerns, and even prolonged use, they have defined when to use them for, like, if this is a typical case where the prolonged use of bedaquiline and delambanate together will be of use. And as Dr. Padma has explained very clearly that in these cases, the WGS or the targeted sequencing will have a role to know which drugs the patient is likely to be resistant, which drug patient is likely to be sensitive. And again, we may have to take the help of the national reference laboratories for this technique. And currently, I think the NIRT Chennai is doing it. They had 4 days workshop also on this, wherein they trained various microbiologists and clinicians on this technique. So even that help can be taken. So once we have tissue or the FNAC material with us, that can be sent to NIRT Chennai lab to have some data, some information using the WGS. So that's all I wanted to say regarding this patient. And the take-home message is that we will keep on getting such cases who are relapsing. So in these cases, try to obtain a tissue specimen or a FNAC specimen. Try to work in that direction. Do all the tests available, genotypic test, phenotypic test, and WGS in these cases to have a good information that to which drug patient is sensitive to, which drug patient is resistant to. And while making a regimen, we have to see which drug patient has taken, which drugs patient has not taken, like Dr. Amish just on a table, that you take the drug wise, whether taken or not taken, and what the lab is saying, whether lab is saying sensitive or resistant, especially from a certified lab, then you can take a call that which drugs we can use. And usually we try to use not more than 6 or 7 drugs, unless we are cornered because of the pill burden is there, and there are ADRs once we use the drugs together. And yes, the newer drugs, bedaquiline and delambanate, we can use them together. We can use them for prolonged periods if it is indicated in a particular case. So that's all from my side. Thank you once again for giving time to me for this particular case. Thank you, Dr. Neeta. Thank you.
Yeah. Thank you, Dr. Singla. We have a question from Dr. Rishi. He has asked the importance of PET scan. Dr. Anuj.
I was trying to answer in the chat box, but couldn't. Well, basically, in fact, we have been involved in studies with there was a project that we are involved with around 10 years back, where we were doing PET scan monitoring for extrapulmonary TB with the INMAS, Department of Nuclear Medicine INMAS. And that is something we found quite useful. I mean, then even we were doing 6 monthly PET scans, and over a period of time, it was found that yes, this is showing a good correlation with the patient's clinical response. But yes, the difficult thing is, more difficult thing is when to decide to stop the treatment, because some amount of inflammation can remain even in a healed lesion. That is something. How do you differentiate between activity and a hotspot on a 6 FDG uptake on a PET scan? But at least here the advantage will be that you can actually get to know the hidden lesions, get it, map it. What I do is now basically map it, right? Do the mapping initially. You will get to find where all is the extent of disease, which all portions the uptake is more, so that you might be having a focus coming up later, or say something that is there which can be actually sampled. You can't sample a tuberculoma, but suppose the same patient had a lymph node in the axilla, the same patient had a focus which was more accessible. We could have easily taken it out in the first attempt, at the first time. So same thing once again with the skeleton. Here, fortunately, it is, but I do not know the extent of skeleton. Like, we have been doing bone scans, recommending bone scans, and after that, whenever the patient can afford, let me be very frank, whenever the patient can afford, it's a very costly test. Whenever the patient can afford, we in fact, even in the last OPD also, I recommended the patient to go at least and explore the PET scans, get it done. Quite a number of patients are coming with PET scans, but the biggest challenge with PET scans is you can't use PET scan to decide when to stop the treatment. And that is the biggest question now that faces every one of us. When to decide to stop treatment in extrapulmonary TB? What exactly is the right time to stop treatment in a patient of extrapulmonary TB, especially if it is a case of recurrent relapse? So that is a big question that will continue to face us, and it will require further research.
Yeah. Thank you, Dr. Anuj. Thank you. It was a very fruitful discussion today, and we all got to learn many new things today. So thanks a lot. I would now invite Dr. Ashok Bharadwaj, sir, Chairman NTF, to give his closing remarks.
Thank you, Nita. So first of all, I must congratulate Dr. Anuj for excellent case presentation by his team. Wonderful discussion by various senior faculty members, Dr. Rajendra Prasad, an excellent comment by the director, Dr. Diwan sir. Because yes, there is the indication for surgery, and Dr. Padma. So Nita, we could not have much attendance today because the sub-national certification for district level annual assessment for TB-free status has been undertaken in whole of the country, and almost 200 DTOs are involved in that. Most of the faculty members are involved in that, and most of the WHO consultants are involved in that activity. So the thin attendance may be due to that. So this activity will go up to 7th of March. Hopefully after that we will improve. So thank you all. It was an excellent case presentation, a unique case, and hopefully we will be having such. I just agree with Dr. Nita, because each state is having their state level difficult to TB clinics, and the cases which are unique in their state should come to the national level, so that each one of us become wiser for the comments by the national expert as well as by the state expert. So thank you very much for giving me a chance. Thank you very much.
Thank you, sir. Thank you so much. And we request everybody to join in, because when we present these cases, we really put in a lot of effort. We prepare the case, we try to bring best of experts. So we want this benefit to go to everybody. So I request all the states, all the district TB officers to join and get maximum out of these clinics. So thank you very much for joining. Thank you, Dr. Diwan sir, Dr. Jai Kishan sir, Dr. Ashok Bharadwaj sir, Dr. Anuj, and all the senior faculty, Dr. Rajendra Prasad sir. You always encourage us so much. Thank you so much, all the state TB officers, district TB officers, STDC directors, Dr. Padma especially, who made a very fruitful discussion today for us. Thank you, Dr. Padma and Dr. Alpa and all others who have joined us. Thank you so much. Thank you. Kindly answer the poll questions so that we get a feedback. Yeah, please answer the poll questions. So next clinic will be in the month of March. Preferably it will be on third Wednesday of the month. And we invite all the states to inform us if they have a good case which they would like to take it to national level. So we will be waiting for your response. You have our email ID, nitrecho@gmail.com. You can put it on the chat so that everybody is aware of the mail. And somebody had asked if they want to send, if they want to discuss a difficult question, difficult patient individualized. So you can send us a mail on this email ID and we will try to get back to you. So we still have very less response on poll. Kindly respond on the poll.